together because this is what I usually do, like patients and medications. And so I like the fact when it's more discussions rather than more like theory. So I think this definitely is good. And when I'm speaking, I guess it will be just the way it is right now. Other people will show up on the screen or no?
Your box is open that people can see you talking.
Okay, all
Yeah.
right.
So I'm gonna, I'll ask you to forward. I'll do the most brief DCPAP. I'll just, introduce the
Sure.
idea of this is why we're here, and I'll just say next, but I'm not going to go through any details.
Yeah, I'll change the slides myself, right? So you don't have to do
if you
right.
don't mind. Yeah.
And you
But
can
I'll ask you just to
start
forward.
recording.
Yeah, just to forward through the housekeeping stuff,
Sure.
just to remind folks who we are if they have any questions. But I'm gonna make that a one minute.
No, take your time, no rush. Yeah.
Okay, now you have 4 people in the waiting room. All right, well, we are at 7:30 on the dot. Shall we?
Recording, remember? Recording?
Yeah, we're recording.
All right, there we go.
Yeah. All right. So I'm gonna go ahead and admit folks and we'll get started.
Sure.
All right. Thank you so much.
Thank you. Thank you.
Welcome, everyone. Thank you for joining us this evening. We're going to hope that we have a few more folks in the waiting room. So if you see a few more names pop up, please don't be surprised. Thank you for attending this evening's presentation, Side Effects of Commonly Used Psychotropics in Children Adolescents. My name is Mindy Webb, and I'm the Behavioral Healthcare Coordinator with the Delaware Child Psychiatry Access Program. I'm going to ask Dr. Gupta, who's our speaker this evening, just to forward through a few slides about DCPAP and tonight's presentation. Just to note, disclosure, distribution, liability, that this information is for educational purposes only and does not constitute a replacement for additional information. It does not replace the provider, patient, or client relationship. It does not replace medical advice or counseling and should be used for information purposes to help build skills around this topic. Next, please. Information that we can ask you to follow up with if you want to get CME credit for this session will be shared with you along with the copy of tonight's presentation. The Medical Society of Delaware has approved this for 1 CME credit, and I'll share this in an email for you tomorrow as well. The Delaware Child Psychiatry Access Program is a grant funded through the Health Resources and Services Administration, and all of you attending obviously have information about our program to have been able to join us this evening. If you want more information, I'll put my email in chat. Of course, you know how to reach me, and I'm happy to address any follow-up questions that you may have about DCPAP. Next, please. If you are not already registered with DCPAP, and I don't think that applies to anybody here, please make sure that you follow up, or if you have a colleague who is not registered and could enjoy the benefits of this resource, please do share it with them. Next, please. And I'm going to just ask Dr. Gupta to forward through these next few slides because this will be again shared with you in reference. And if you have questions about the specifics of DCPAP or consultation services, next, please, Dr. Gupta. We'll just forward through information, and next, please. We'll just go right to the start of tonight's presentation. Please do make this an interactive opportunity. You can unmute at any time to share questions or case scenarios. You can share questions or comments in the chat, and I'll monitor those for Dr. Gupta, and we will make sure that your questions and the need to just discover more about this topic is best suited for your patient care needs. Thank you. Dr. Gupta, I'm going to introduce you. Dr. Gupta is one of our consultant staff and adolescent psychiatrists. He is the medical director of Rockford, and we're so glad to have him with us tonight. Dr. Gupta, thank you.
Thank you. Thank you. And good evening. And I really appreciate the fact that you took the time to come here this evening. And I know we have been going through different modalities, and some of the lectures have been in the daytime, and we decided to have one in the evening, especially for the prescribers, and see how that works out. Now, please let's make this as interactive, and I'm totally open to stopping at any moment and we can start a discussion, or if something rings a bell and you want to raise a point right there, please feel free to interrupt. That's the whole point of having a smaller group and a more cozy kind of a discussion here. Now, the learning objectives here are that basically, as mentioned above, that we'll be able to identify side effects of commonly used psychotropic meds in children and adolescents, and as well as the stimulants and the non-stimulants. Now, the reason we decided that this should be a good topic is because we all use a lot of these medications, and some of us more than the others, especially say in psychiatry, I'm using them like literally every day. You are also using them a lot, and I'm sure that there are times when, because we are not sure what's going to happen, what are the long-term side effects, or what might happen, that could be a factor in deciding how aggressive we should be. So we thought, as DCPAP, that this would be a good discussion point, and this could be a good way to start. Now, the most obvious question to start with is, what is a side effect? Now, as you all know, again, this is the CDC and the FDA both define a side effect as an adverse reaction. Though interestingly, the WHO defines a side effect as the unintended effect occurring at a normal dose related to pharmacological properties. Now, a lot of times, medical practitioners and researchers define side effects as secondary or unwanted effects, or as the unintended effects of a therapy. But now, focusing on the practical aspect, the goal is to look at what are the common side effects which we come across. Now, again, I'm very cognizant of the audience here, and also know that we are not talking, say, as a group to psychiatrists. So I'm trying to keep it hopefully as useful as possible and as simple as possible, and then build it up from there. So this is not factoring into things like an acute allergic reactions, which are acute and usually would obviously result in you stopping the medication as soon as it is prescribed. So let's start with stimulants, because I guess that's bread and butter for a lot of our patients who come and have ADHD medications. And I'm not going into what are the stimulants, but in general, if we look at, okay, what are the most common side effects of stimulants? In specific order, if we go with the percentages which we come across, usually you would come across headache, stomach aches, decreased appetite, lack of appetite, weight loss, dry mouth, sleep disturbance, and insomnia. Now, we could very briefly talk about each of these side effects because they're always present in different ways. A lot of times when you start a patient on a stimulant, they might come back and say, well, he took the medicine and after about 15-20 minutes, he reported a headache, which lasted for a few hours and then went away. Usually, I would suggest that that is one of those features that once we have this, we should try some alternative medication. But at least we should start off by identifying how often does the headache happen, where is it happening, is it happening after you've taken the medication or not. Similarly, the issue of stomach ache is usually reported in younger kids when they take the medication and they report that within about 10-15 minutes, they're having stomach aches, which incidentally then causes them to not eat. And so now there's a lack of appetite, and so they're not eating lunch. And eventually, by the time the medicine wears off, the stomach ache is gone. So it's very important to be aware of this very common side effect. And linked to it is the fact that there is a decreased appetite or lack of appetite. Now, because we are missing lunch or we're missing the majority of the meals during the day because of not wanting to eat, there could be a weight loss, but there are ways to mitigate that. Usually, what we would suggest is, okay, why don't you eat a heavy breakfast and then take your medicine, and then wait for the stimulant to wear off and then have two dinners. I usually suggest having a dinner and a supper, and so that we can then objectively assess the weight loss. Usually, I do not suggest that there's any evidence to show that you should prescribe supplements, because the weight loss is not because of a medical reason, but because the medication has caused less appetite. So it's better served by having them eat later in the day or before taking the medication. Now, sleep disturbance is commonly seen with stimulants if the stimulant is given closer to the bedtime. Stimulants is one of the most common medication which you can actually time it using a stopwatch. And I've had parents do that on a weekend and say, okay, give the medication and actually see how effective is this medication and when do you see the medicine wearing off. And it's very interesting to see that you can actually time it. Parents can time the medication and say, this is exactly when the child is not sleeping, or the child is suddenly more awake, or he is more drowsy. So that is a factor when we consider lack of sleep insomnia in these children. Now, most common side effects which sometimes we do experience is that a child may come and say there's an increase in the heart rate. Any stimulant, usually, even if it's a long-acting stimulant or a short-acting stimulant, as soon as it is converted into the active ingredient, you do see a transient increase in heart rate, which has been shown that it does subside in about 10 to 15 minutes. But if we do not tell the child about it, or we do not tell the parents about it, we find that the child or the family comes back and says, we stopped the medication because it increased its heart rate and we were not sure what to do about it. There's also enough evidence to show that there is a transient increase in blood pressure. Usually it's up to the range of 30 by 15 in systolic/diastolic. And again, serial studies have shown that it's usually done in about half an hour to an hour after taking the medication. It's important to be aware of these two, because you might find many children coming back and you would go back and say, oh, if only we had talked about this side effect before, the family would have stayed with it. And over a period of time, the transient increase in heart rate is not sustained. A lot of patients along with this would also identify that as palpitations. There's also increased anxiety with stimulants in some people who are more prone to it. Not everybody would have anxiety, but some people do come and feel that they're hyper-focused, and then they become more anxious because primarily they're more aware of not only physiologically the heart rate has increased, they're feeling as if something is not right, my heart is going faster, and if they're prone to anxiety and I'm very hyper focused on something, so they'll come back and say my anxiety definitely increased. Something which is commonly seen and not that common, but interestingly, I just saw two patients today who had the same side effect, was cold extremities or purple or pale fingers. Now, this is called Raynaud's phenomena, and you will find some patients who have been taking stimulants and they'll report, oh yes, my fingers turned purple, or my fingers did turn into a different color. And especially if it is colder, it is worse. And when you ask them that, okay, what happens if you don't take the medicine, then they will report that this only happens during extreme winter times. The patient I saw today actually was on Vyvanse, which is the long-acting stimulant, has been having this, but he had tried all of the stimulant medications and felt that the only way it would really effectively work for his attention is being on the long-acting stimulant. But then he was willing to have some cold extremities and compensated by either wearing gloves. And I told them to go to Wawa and buy some hand warmers, because it's not, once obviously you have been medically cleared, once you're sure that it's not Raynaud's disease and there has been a systemic investigation about it, then it's basically a Raynaud's phenomenon, which is directly related to the stimulants. Now, it is interesting, some patients may not feel discomfort, but they may notice some change in the color of their fingers and toes. So it's always good to kind of keep a lookout, and especially with winter coming up and starting stimulant on a medication. If we warn the parents about it, just watch out for any changes in color skin. That may not be a that may be a very good idea. We also see a lot of mood fluctuations sometimes with stimulants. Again, not everybody has mood fluctuations, but there is inclination to become a bit more irritable at times. Now, there also have been times when a stimulant can actually make you much more aggressive and agitated. And that's not a common side effect, so I try to tease it away from it. Rather than when a patient is started on a stimulant and becomes, say, very aggressive or very depressed, that to me would be more of a more serious side effect than a common side effect. But some mild mood fluctuations would be seen with stimulants. Agitation, again, as I mentioned, can be both mild and extreme. And again, depending on the clinical response as well as how the patients and the parents are feeling about what they feel is there, would be a good factor in titrating the dose of the medication. Now remember, the ADHD by itself would cause increased irritability. The ADHD brain is going so fast that it cannot keep up and with the slow people around them, and there is a tendency to be more irritable, which means that they are already prone to having some mood fluctuations and mild agitation. So if a stimulant is added and that makes it worse, then we know to back off on the stimulants. Some patients have also reported more commonly in older adolescents and adults as psychosis and hallucinations. It's not that common. Mood swings are much more common, but you do hear at times that the patient was started on a stimulant and started hearing voices, or he really became aggressive. Usually when this happens, it is usually very acute, so it's very easy to identify. There have been some reports of bruxism, which is teeth grinding. And what studies have shown is that possibly it's more common with the Oros related stimulants. Oros, as you know, is the one, for example, the extended methylphenidate, or commonly called the Concerta, which has the plunger technology, so that there is an oral reabsorption osmotic system. And for some reason, it's not very clear as to why bruxism has been associated with some Oros-related products. Tics is something which will come up a lot. Patients are started on a stimulant and they may develop any tic. They can have a motor tic or a vocal tic, and then suddenly the parents will come and say, well, the stimulants caused him to have tics. As I'm sure we all know here, is that tic is not a side effect of a stimulant, but a stimulant lowers the threshold to have a tic. So, and it has again been shown, and I'll provide references, is that people who develop tics on stimulants would have had developed tics independent of being on a stimulant. The stimulant just lowered the threshold for them to develop tics. And usually when you see tics, the management of the tics would either be try to change to a different medication, lower the dose of the medication, try a non-stimulant. Again, it's much more common with a stimulant than a non-stimulant. Going back, now coming to non-stimulants, there have been some newer non-stimulants, but one of the ones which has been around for a very long time is atomoxetine or Strattera. Now, the most common side effects with that is any GI disturbances when it started, could have some nausea, dry mouth, constipation. Occasionally, there will be feelings of tiredness, and the child would come and say, "We started the non-stimulant, and he's very tired all the time." Usually, for tiredness, it has been again, we can use twice a day dosing. So it's not uncommon to have atomoxetine being used in twice a day dosing in such patients. The GI side effects usually subside over a period of time. Urinary retention is one of the lesser known side effects of atomoxetine, and the most rare, but again, if there was one side effect which is very permanent and can potentially be life-threatening, is liver damage. So anybody who's a non-stimulant should have at least a liver function test at least once a year. It is not a common side effect. The incidence is really very, very low, but because it can be dangerous, it's always recommended that at least do a liver function test once a year. The other commonly used non-stimulant is guanfacine, or also commonly used as 10X, or a long-acting version is Intuniv. What you commonly see with that is drowsiness is very common. Now, usually drowsiness is, again, after a few days, a person does get used to the medication, is not as tired all the time. Sometimes in a younger child, like a 5 or 6-year-old child, if I'm starting guanfacine, I would suggest even starting at 0.5 milligrams twice a day. And the parent would come back and tell you that the child was so tired and sleepy, but after about 3-4 days, things were fine, and now the motor activity is definitely better. And related to the drowsiness, we have fatigue. Patients can complain of nausea. You do have to monitor the blood pressure. Sometimes these children may have a fall in the blood pressure. And again, the other common side effect which we can see somewhere is dry mouth and constipation. Clonidine, the other one which is commonly used, especially at night. We use the side effect to our advantage because sedation is a side effect. And apart from that, we also have issues with dizziness, which is usually because of postural hypotension. Though it's hard, but we do tell the child to try and get up slowly, but good luck with that with an ADHD child. But again, we tell the parent, and usually we give it at night. There are times when clonidine is given during the daytime also, and I think that's the time when it's all the more important to make sure that the child is not running fast. Let me see what that. Then there is viloxazine is something which just came out, known as Quellbri, and usually it's an antidep. The way it works is through the whole system of antidepressants. So the common side effects are listed as they would be for an antidepressant also. But typically, the most common side effect actually I've seen is sedation and tiredness, along with some GI side effects, including loss of appetite, nausea, vomiting, which goes away after some time. Now, because it's an antidepressant, the way it works is as an antidepressant. Anybody who uses MAO medication or monoamine oxidase medications, which again, not many people are using MAO inhibitors now, but there should be some caution when we are using the two medications simultaneously. So if there's any questions about any of the stimulant medications or non-stimulants, please feel free to interrupt at this time. Now, again, I do bring up the fact that all these medications, especially like viloxazine and atomoxetine, because of the identification with an antidepressant, have those black box warnings. And it's always good to bring up with the parent that there is a black box warning. It's not technically a side effect, but I think it's so important that I put it in there. It should be discussed because of the potential implications. And that's the first thing a parent sees when they pick up medicine at the CVS. There'll be a big black box warning and they'll say nobody told us about it. Switching gears to antipsychotics.
Dr. Gupta, before you go on to that, I just wanted to share my thing with the atomoxetine. I heard somewhere that, there's in some conference that if you give it exactly like in the middle of a meal, it makes a big difference. So I literally tell them, have half your dinner, take the medicine, then have the other half of the dinner, literally sandwiching the medicine in the food. And I've had very good luck, and they don't have any gastric side effects, but they've said they didn't believe me one time, and they did try to take it without doing that ritual, and they definitely suffered, and they went back to doing that. So just a helpful hint, it really has made a big difference. So yeah, so I say whichever meal you are definitely going to eat properly, and you could, whether it's breakfast or dinner, most likely, it really helps.
Thank you for sharing that. That's very useful to know. It's a pearl of wisdom. We can put it in that. Along that, another one which I would like to share is that with some stimulants, they say that if there is an acidic base in the stomach, the absorption of some stimulants is less. And it's very interesting. You might have a child come in doing well on the same dose of medication, but then at times when he's visiting the grandparents, it's not as effective. What you find is they're taking the stimulant with orange juice or grape juice, while at home they're taking it with water and milk. So I routinely tell everybody to just take the medication with milk or water and no juices at all. This is mostly common with the methylphenidate salts. And when you look at the side effect profile, say on CVS or whatever, it's maybe number 92 or 93 listed there, that do not take anything with citric thing, but I think is so important because it has clear-cut ramifications in how a child responds. Moving along to, but thank you for sharing that, Dr. Vaidya. Antipsychotics. So what is the most common thing that people are worried about? They want to know, okay, will this patient, and especially the young girls, will have a weight gain, and boys, and that's the most common thing that patients and families worry about. It's very important. It's part of a guideline that we do need a baseline comprehensive metabolic profile, especially in the first week, and then after maybe 4 weeks, and then repeat in a month and 3 months. And after that, the guidelines are that it should be done at least every 6 months. The usual mechanism for weight gain is either the H1 or the 5-HT2C blockade. Now let's look at what are the more commonly used medications that we are using: olanzapine, risperidone, aripiprazole, and quetiapine. So again, if you look into this, and this is the weight gain, if you look at studies, they will show that olanzapine has been known to cause the most weight gain. So it's in that particular order, and quetiapine definitely causes less weight gain. And then I'll come to Geodon here also. Now, what is, let's see, what are the common side effects in terms of percentages? Like weight gain, again, we see that yes, it's a factor, but it's not happening to that extent. What people say, okay, we are fatigued, there is tiredness, there's some constipation and dizziness. The thing which we also need to worry about is movement disorders. In adults, people are always used to tardive dyskinesia, extrapyramidal side effects, that patients are having all these kind of tremors. We forget about that in children, but these medications are associated with a lot of movement disorders, and I'll come to that also. Weight gain is actually seen in less than 4%, but I don't totally believe this source. But again, it's the most talked about. Here are some references as to what were these results based on. There were these studies which were comparing adolescent and adult patients who had taken olanzapine for at least 24 weeks. And then it compared the incidence, and I won't read everything on the slide here, but it does tell you that it was definitely associated with weight gain as well as increase in blood sugar. Now, studies in adolescents and children are much less than they were in adults. When these medications came out in the 90s and 2000s, all the studies were based on adults at that time. But gradually, the literature expanded, and so now we have more data to support that. Now, there is like how many people think that weight gain stops after the first 4 weeks? Do you think it's true or not? Because that's what the drug companies would like you to believe. Now, studies have shown that that's not true. Despite a notion that they plateau after the first 4 weeks, multiple studies have shown the maximum weight gain happens in the first 4 to 6 weeks, but it does not stop or plateau after that. It continues to be a factor. So we will hear that, oh, the weight gain, if there's not there in the first 4 weeks, then maybe you should not worry too much. Partially true, but that's also based on the fact that there's maximum weight gain in the first 4 to 6 weeks. But again, it's not that it will stop after that. So what can we do and how do we monitor apart from the obvious? The obvious meaning diet, exercise, and other things. Now, the single most thing which everybody here, I'm sure, does is the waist circumference. Now, the waist circumference is important to measure in children adolescents, especially, again, this is in no particular order, but for all the patients who are on any of these medications, Abilify, olanzapine, quetiapine, or risperidone. And they actually showed evidence that there was some use, and the measurement of the waist circumference should be done at baseline, then a month after that, then 2 months, 3, 6, 9, which is kind of parallel to a recommendation for the blood work. Now, and this is an interesting study, but they did see that the average increase in waist circumference after 4 weeks was about 3 centimeters with quetiapine and risperidone and 4 centimeters with olanzapine. So I'll be very interested in knowing how many people here who have been prescribing this use that as a tool also. Again, this is further evidence and studies. This is a study which talked about what should be done. They also found that the BMI was increased. And again, the BMI was increased in no particular order, but if you look down further, olanzapine was the most, and then there was risperidone, and then quetiapine, and aripiprazole was the least. This is a free resource which I have it like to give to any parent who says, okay, what about weight gain? How should we monitor? And I'm sure everybody has been using it, but you can just send this link to the parent and say, this is a free resource. This will give you exactly what the guidelines are by the ADA, the American Diabetes Association, and the APA. And apart from weight circumference, what else to measure, how often to measure. So I think this is a more comprehensive way of telling the parents where to go to the real source, which is not pharmacologically driven and would be very helpful. Now, some of the things which you have been using or hearing about is the use of metformin. Metformin is not a weight-reducing medication. It's not something that you can use an anti-obesity medication, but it does reduce weight in patients or prevents further weight gain when somebody has gained weight because of antipsychotics. It reduces weight gain, BMI, fasting glucose, and insulin, and as well as a total cholesterol. The average weight loss with metformin was 6.5 pounds, and hypoglycemia was rarely seen. And there is a reference listed for that study, but it's been very useful. It is still not FDA approved, so always be careful of saying that it is an off-label indication, but has been shown to be very effective, especially in patients who have antipsychotic-induced weight gain. So how does it work? Essentially, it blocks the production of glucose in the liver. It increases the peripheral insulin sensitivity, and then it also reduces the increased appetite that the antipsychotics cause due to their effects on the brain. Now, there are also studies which showed that it also lowered gastric emptying due to stimulating the secretion of glucagon peptide and possibly affecting some hormones, including the hunger and satiety neurotransmitters in the brain. Now, it's important to know, it does not increase the release of insulin, and it only partially reduces gluconeogenesis in the liver. So that is the reason why you do not see hypoglycemia. Has anybody been using metformin for antipsychotic-induced weight gain here? And
I used it for anyone with starting with antipsychotics. I use it simultaneously. You do have to get it approved. And sometimes they have a little diarrhea or tummy ache in the beginning, but they mostly tolerate it pretty good.
so are you using the extended release, metformin extended release? Because
There's a liquid form because these kids are taking liquid, so twice a day.
okay. So the two, if they can tolerate the oral tablets, extended release will take care of the GI side effects.
Yeah. Okay.
So, and usually they say you should go in the range of 500 to 1,000 milligrams twice a day.
Wow.
And the third, and again, this is in older adolescents, but also now there are some schools of thought in terms of whether it should be started when you start an antipsychotic, or should you wait and when you start seeing a weight gain. So that's an interesting discussion, whether it should be started right away or should you wait and see before adding metformin, because as you have seen, not every antipsychotic causes the same amount of weight gain.
So one question. So I waited like for the first visit and I did see a weight gain, and despite counseling even before starting it. So I did start it after like maybe 6 weeks or so. But I have a couple of other kids who do not have weight gain, but the hemoglobin A1C is abnormal still.
And was that A1C abnormal even before starting the antipsychotics?
No, it was after.
So after, so that means their blood glucose definitely went up.
Yes, and they both are like skinny. They're not heavy.
Right.
Both were having higher level of rice eaters. So I did tell them to cut back on the rice, especially the jasmine rice. So let's see, have to follow up.
Right. No, that would be a good, interesting strategy. But a lot of diets, I would say, eliminating carbohydrates, especially rice and bread and pastas, can definitely help also. So I think having a nutritionist or a dietitian be involved in that might not be a bad idea too. Now, it does affect, even if there's no increase in blood sugar. So interestingly, your case actually already the A1C was high. But what they have shown in the study was that even if the A1C was normal, metformin was still effective. And again, more likely response, as you said, was younger patients, recent starts. Some people say before the weight gain starts, even on early stages. So there's nothing. Like there's a strong argument to be made that it can be started earlier also. As I said earlier, metformin extended release better tolerated, starting with 500 milligrams, and you can go up to 1,000. It's usually much better tolerated than the regular metformin. People have also been talking about topiramate for weight loss. Now, there were some 8 random control studies for weight gain on second generation, and they did find that topiramate also decreased the weight. Average was 6.2 pounds in this study. But the issues with topiramate were that it does cause some cognitive dulling, and there is a definite risk of increase in renal stones. And there are more interactions of topiramate with other medications compared to metformin.
Dr. Gupta, I had a question about renal stones. Is that regardless of age or length of medication use?
Yes, it's based on the way the medication is processed in the kidneys, and I think increase in uric acid or the formulation. So that's not dependent on the weight of the child.
Thank you.
I did mention earlier that we have to be aware of tardive dyskinesia and extrapyramidal side effects. Now, in the child world, people don't really come across tardive dyskinesia. Now, that is something which till a few years ago was considered as untreatable and very commonly seen in the younger population, starting on the classical dopaminergic antipsychotics like Haldol. The whole reason the second generation antipsychotics came around was because they were less likely to target the D2 receptors or the D3 receptors, which were causing the tardive dyskinesia. But again, over a period of time, like everything, it showed that even they cause movement disorders, which can result in tardive dyskinesia. So when we start seeing anybody who is on any of these antipsychotics and start developing any extrapyramidal side effects or other movements, you should try to get off the medication. The strategy is to take, because this is something that a child can live with all his life. Now, there is a new medication which has come out, Ingrezza, for adults, which can prevent from tardive dyskinesia from progressing, but again does not stop it. Usually you would say taper off the anticholinergic, stop the dopamine blocking medication, saying that trying a second generation obviously is there, but because even now a lot of people are using haloperidol, which commonly is causing TD much more. So you would want to avoid that. And the VMAT, this last one is what the new medication have come out in the last maybe 4 to 5 years. Again, these are studies more for adults, and VMAT is not approved for children and adolescents, just for knowledge. Now, we all use antidepressants, but I thought let's focus on some of the side effects which adolescents and even adults complain of, and we don't realize that that's a side effect. This is one of the lesser known side effects of an antidepressant. When the kids would come and say they sweat a lot. Literally, they would come and say that he sleeps, the child is sleeping, and they wake up, the sheets are all wet because there's increased sweating. Once you start asking about it, you'll find that these are the percentages of the medications. Like interestingly, bupropion, 22% of patients on Wellbutrin have reported sweating. Venflexazine, citalopram, Paxil, fluoxetine, sertraline, and Lexapro. It's very common in that percentage. If you compare it to the other side effects, it's much, much more common than what you would expect. And if you don't ask for it, patients would never think that this is a side effect of antidepressants. So I thought it would be interesting to bring it up. The question will be, what do you do with it? You wait and watch. If possible, you reduce the dose. But then if the patient is, okay, this is the only medication that has been working, I can handle the sweating. There are two options there. Terazosin is an alpha blocker, and glycopyrrolate, which is also used very effective. I have used both of them in a lot of adolescents, off-label use, but also very effective. Literally, you had a mother saying that my son used to wake up, I had to change the sheets. Initially, I thought he was having accidents. And once we started Terazosin, there was like day and night. So it definitely is there. Just ask for it and you'll realize that, oops, this is something we never thought about before. Glycopyrrolate does not cross the blood-brain barrier, so sometimes people like to use that more. Orthostatic hypertension, I had briefly touched upon it briefly, that especially in clonidine, we're using for ADHD for children. The nighttime is not that much of an issue, but sometimes we use clonidine in smaller doses during the daytimes also. If for some various reasons we are not able to use the stimulants, or we are finding that the child is responding better to the clonidine, you have to counsel the parents about not trying to get up too fast. Most commonly, obviously, you go to the restroom, get up, fall down there, and we see that in geriatric population, but we also see that in young children. Trazodone, a lot of us commonly use it for sleeping purposes or also sometimes as needed if somebody is getting very anxious or agitated. Can also cause significant orthostatic hypertension. Now, to actually document it, and if you're very particular about it, the mean change or drop has to be 20 millimeters. You take the blood pressure of the patient when he's lying down and then tell them to stand up and immediately take the blood pressure. And if the drop is more than 20, it's considered technically orthostatic hypertension. Tremors are not so common in children as in adults. Tremors can be seen with SSRI medications. Tremors can be seen with all of the antipsychotics. And again, we are not commonly seeing them in children that much, but still, if you want to say, how do I watch for tremors? Because children are always on the go. I usually tell them to take a paper and just draw a circle on it. And interestingly, if you see over a period of time, you'll see how that writing sometimes does change. Anxiety can cause tremors. One of the common medications which we forget about at times is that lithium does cause tremors. Lithium causes fine tremors, which are considered as a common side effect. But if they become coarse, then they are considered as a toxicity. So that's a very easy way to differentiate it. Have the adolescents stretch their hands out, put a big piece of A4 paper on their hands, and you will see the tremors get exaggerated, and you can easily see if they're shaking and how much is the frequency. Again, coming back to akathisia or restlessness, something to always think about is, okay, the child is on Abilify, he's moving a bit more. Now, before we say, oh, this is akathisia or EPS, we should also think that this child could just be a bit more hyper, or he could be anxious, or because we're all adults looking at him, he's scared, and we are in trouble syndrome. So after we rule out, only then we should look and say akathisia is a factor here. Especially if a child is on risperidone and Abilify along with other SSRI medications. The other common extrapyramidal signs which you do see is sometimes is stiffness of the arms and the legs. Sometimes not so common in adolescent, but you might see some drooling. Again, these are the chronic ones that I'm describing. You also sometimes see acute dystonia when you take the child takes the medicine and suddenly they present with acute dystonic picture, which is very scary, and the child or the parent would never give you that medication again, even though it's a benign side effect and very easily reversible within 15 minutes by an oral or IM medication. Now, there's some overlap between management of the child, adolescent, or adult. You do want to either change the medication or reduce the dose. Think about alternative medicines. But if somebody has to be on those medications, then you can consider adding propranolol or low doses of even benzodiazepines or mirtazapine. Something which we don't commonly ask adolescents is the sexual side effects, especially you would see a lot of adolescents between the age of 14 and 17 who do not want to be on antidepressants because obviously they have all looked up. They say, okay, I'm supposed to be an antidepressant and it affects my sexual functioning. So that itself is more than enough for them to say, okay, I don't want to be on SSRI medication at all. It's a real side effect, obviously. Now, there are no specific studies in children as to the incidence or prevalence of the adult sexual side effects. What's more common and what's less talked about is priapism. I've seen at least 3 cases of priapism in the last few years here. And that is a very, very painful condition. The child had to be sent to the ER and has to be managed there. Very common with trazodone, which is also interesting because we use trazodone a lot because the child is not sleeping in male patients. So always be aware of it. It's okay to tell the parents about it because you want them to know of this rare but like a side effect which can happen. Not very commonly seen, but if you use enough trazodone, trust me, you will see them. The management is you send them to the ER, use some anesthetic creams, or in extreme cases, penile injection, which I've only seen being used once in an adult many years ago, but not in children. I always like to give the parents these three websites because these are non-controversial. Clinicaltrials.gov is actually the best website because you can think of any medicine, go to this website, and whatever relevant studies or data is there, you'll be able to see it there. And that's the easiest way to tell and educate a family about it and say, go on this website, look for whatever you're looking for, then we meet next time. We can have a good discussion about it. I also use it a lot, and including the NIMH and the medlineplus.gov. These are some of the references and the articles which I have added, which we used. And I know that it is a late night, but did anybody have any questions, or should we open this for any discussions or any comments? The goal here was to kind of limit it to what we see more commonly and some of the rare side effects like the sweating and the priapism, but is there any specific questions or any
Anyone can feel free to unmute or share a question or comment in the chat. In addition, I put into the comments, please note that this is not the only opportunity to ask questions of Dr. Gupta. You can email me, mindy.webb@delaware.gov, and request a consultation with Dr. Gupta or any of the consulting psychiatrists around medication management, diagnosis, treatment planning, or request resource or referral support as well. So, but this is what we're here for tonight. So I hope if you have some energy left at the end of the day, you'll take advantage of this one-on-one live time.
And I guess I put this here, that's why nobody's asking questions.
I think you had such great information to share. I actually have a question as a parent. Looking at some of those concerns for side effects, if you have a child who's, in the window of puberty, do some of the medications affect the process of puberty? Does it, delay some of the growth potentially, or?
No, it doesn't, but only if it affects the appetite, and we are monitoring them very closely. The stimulants, this is a common question we have with stimulants. Parents don't want it because they've heard that it, stunts the growth and so on. But we often tell them we are monitoring them closely, and the only way it affects the height is by suppressing appetite. But we always go up very gradually, so that's not a problem. We have kids who are actually obese on the medicine, so it's obviously not a permanent appetite suppressant. And if it was a permanent appetite suppressant, we wouldn't be spending thousands on Ozempic, and we wouldn't have so much obesity. So no, it doesn't really suppress the height or affect puberty.
And no effect on starting a menstrual cycle or things of that nature for puberty? No, okay. Thank you.
And for people like along those lines, when people are worried about weight loss, now the common question which is always asked is, should we stop the stimulants on the weekend? Or sort of like the studies have shown, and my response is that, do you stop eating food on the weekend? ADHD is not just for studies, it's a lifestyle thing, it's for everything in your life. And if you have to stop a medication because of side effect, I would rather change the medication than stop it on a weekend. Only in some cases where you have tried a few and come to the conclusion that this is the only medication which is tolerated, so then we can discuss the concept of not giving it on the weekends or taking drug holidays. Now, drug holidays are effective and have been shown to be useful and helpful in regaining weight and appetite, but studies have also shown that the efficacy of medications can be variable in patients who are taking it erratically. So if you are taking a medication Monday to Friday and then stopping for 3, 4 days and starting it again, versus somebody who's taking a medicine 7 days a week, you'll have a much better functioning of the patient who has been taking it 7 days a week. So the challenge there should be to either change the medication or maybe lower the dose for the weekend, but definitely continue that. But again, every patient is different, every parent is different. So it's not like a set in stone answer, but that's some strategy to be used.
Dr. Gupta, we do have a question in the chat. Dr. Gola is asking around preferences of antidepressants for a child with depression and migraines.
So that's a good question. Now, anytime when we talk about an antidepressant for a child, we have to start off with what are the 2 FDA-approved medications for depression. And that's fluoxetine and escitalopram or Prozac and Lexapro. These are the only 2 FDA-approved medications for children with depression. And ideally, you have to start with one of these two. Though having said that, all antidepressants have been shown to be equally effective, and if the parent is comfortable with the off-label use, you can start any medication. Now, the question becomes in terms of migraines. Most antidepressants would cause headache as a starting side effect. But if somebody has to have, I would go with a very low dose. I would start off with maybe something even like Lexapro 2.5 milligrams and then go up as tolerated, because headaches are not a common side effect of antidepressants, so you will not see it with everyone. So if this child is having both and an antidepressant has to be started, I would start with the lowest possible dose. And in this case, if specifically asked which one, I would most likely go with escitalopram 2.5 milligrams. I'm not sure what the age of the child is.
Thank you for that consideration. It's a great resource to have. In the interest of time, we have about 4 minutes left. Any last questions or comments for Dr. Gupta in this live hour?
Just one question. Sometimes you have two problems like depression, anxiety, and coexisting migraine, and we've used both. So if I have to use a migraine prophylaxis in a kid who's a little bit on the heavier side, I don't want to use cyperheptadine. And I've used amitriptyline, and normally it's supposed to not be used together, but have had no other choice. Is that okay? And
it's actually perfectly fine. Amitriptyline is a gold standard, and for some of us who, if you look at the literature from the 1980s and 90s, amitriptyline and imipramine were the classic antidepressants which were used and have been very effective. And then they basically fell out of repute because they were being used in higher doses, causing a lot of constipation. But the bigger side effect was the cardiac side effects at higher doses. It's interesting nowadays, if you send a child, and I've had this happen to me, who's on antidepressants and had migraines, went to see a neurologist, and the neurologist added 25 milligrams of amitriptyline. Because that's very safe and a good medication for headache.
That's what I do. All right. I start with 10 and go up to 20 maybe. Yeah.
Right. But again, I've used a lot of amitriptyline in the past, and the way to do it, and I would not suggest to do it in this group, but to do an EKG first and monitor carefully and maybe have a cardiologist involved. But it is a very good, effective medication, and both imipramine and amitriptyline and desipramine have been shown to be very effective, and studies actually have shown that the clinical responsiveness to as an antidepressant uh, is no different than fluoxetine or escitalopram or the newer antidepressants. But that's a conversation for a different day.
Dr. Gupta, thank you so much for your time. Just a couple of quick housekeeping notes before we end tonight. If iPhone 142, whoever's moniker that is, could email me their name and title so I can make sure that you are cross-referenced with getting credit through the Medical Society of Delaware, that would be helpful. Please note that Dr. Gupta will actually be the host of our live weekly office hour through DCPAP tomorrow. If you are a registered prescriber, you would have received that invitation in your Outlook, and I'm happy to give that information to you. You will receive a copy of this presentation for your reference in an email from me tomorrow, probably not tonight, along with the reminder of how to claim credit through the Medical Society of Delaware, as well as some information around our upcoming presentation on December 5th, the next in this set of presentations around ADHD treatment updates and new medications on the market with Dr. Narpinder Mali. That will be an early morning session. As Dr. Gupta said, we're trying to vary the time to help meet the needs of all prescribers and the variable schedules that everybody has. I thank you all so much for your time and participation this evening, and especially Dr. Gupta for your expertise and taking the time to create this presentation for our reference. This training will also be recorded and shared through our learning management system ongoing. Enduring credit will not be available, but the information and the recorded live presentation will be available for enduring viewing. Any last questions for me or for Dr. Gupta before we say good night and wish you all a good evening?
Thank you for taking the time.
Thank you all again. And again, thank you, Dr. Gupta. Please send any questions to me via email, and I wish you all a great rest of the night. Take care.